I think that way we could communicate in an easier way. Okay. Today's topic is acutely ill child resuscitation. Well, we explained a little on assessment, and then we're going to explain about resuscitation today. Okay, the very important thing in resuscitation is to provide oxygenation and perfusion. I was going to explain the details on which your book has talked about, but I think it's better to have a practical class because you have your book and you can study whenever you want, but the important thing is that you get to know better the practical topics. Can you tell me if you can hear my voice clearly and if everything is okay? Because I want to go into CPR algorithm. Can everybody hear me? Oh, okay, I will do full screen, sorry. Okay. Okay. I hope that you remember that in the last session, we talked about general assessment. We said that if we are in a scene, in a park, for example, and you find, if you find a child unconscious lying on the ground, we will ask him or her if she's or he is okay. We will say, are you okay, honey? Are you okay, dear? Are you okay? And if that person does not answer, can you say what we will do? Can a courageous student answer me? What will we do if we ask the patient, we ask the lying on the ground patient if she's okay and she does not answer? It's okay if you turn your microphones on. I would like that very much. If not, you can type in the chat. Someone saying A, B, C, D, E, F, G. Zahra says we shout for help, check breathing and pulse if it is present. Yes, it is closer to what I meant. Irfan, I said that the patient is not answering me. I asked him if he's okay and he did not answer me, okay? This thing that you say, A, B, C, D, E, F, G, is for the time that the patient answers. Says something like, I'm not feeling well, I'm ill, I'm feeling bad, something like that, okay? So if the patient answers and if she or he is conscious, we will go for A, B, C, D, E, and that's for primary assessment. But if he does not answer, we should shout for help. We should shout for someone to come and call an ambulance with AED or automated external defibrillator. And then we will start the BLS algorithm, the very important algorithm about which I'm going to talk today. Okay, and I will explain about this AED here too. Okay, so okay, this is the basic life support algorithm. I have changed a little bit the shape because I wanted you to get to know it in any way that you see it. Okay, the first thing that you should do, as our dear Zahra, I think, has said, is that you should check for central pulses. You have found, I repeat, you have found a patient unconscious on the ground. You asked him if he is okay, and he did not answer. You shouted for help, asked for an ambulance, and then you should check for central pulses. Central pulses are very important to get to know too, because unless you can check the central pulses, you cannot continue the CPR algorithm. What pulses should we check in a child less than 1 year old, in an infant less than 1 year old? Can anybody tell me what pulses we should check? I hope that all of you are here and are listening to me, because it seems that only our two dear students are listening to me, Mustafa and Zahra. Oh, Irfan was his name. So should I say it myself? The pulses that we should check for the less than 1 year old, somebody has answered. Carotid is not adequate. Brachial is good, I think. This is right. You know why we should not check the carotid pulse in the less than 1 year old? Because it's hard to find. The neck of the infant is very fatty. It's hard to find the carotid pulse. So we will check for brachial or femoral artery. But for a more than 1 year old, we can check for carotid too. Okay. So you check for central pulses. You have only 10 seconds to do this. For more than 10 seconds, you will just lose the time, okay? So you will not have 15 seconds or 1 minute to check for the pulse. If you are definitely sure that you have found the pulse, then it's okay. The pulse is there, so you can just ventilate the patient, okay? But if you cannot find the pulse or you're not sure that you have found the pulse in 10 seconds, then you should go for the CPR. First of all, you will give a rescue breath. It means that you will give one breath every 2 to 3 seconds. Okay, every 2 to 3 seconds, you will give one breath, and you are hoping that after 2 minutes, your child's circulation will be back. Okay, so you will continue doing that for 2 minutes, and then after 2 minutes, you will check again for the pulse. If still there is no pulse, so now is the time that you will start chest compression plus ventilation. Okay, after 2 minutes of ventilation, you will start chest compression plus ventilation. And how should you provide this chest compression plus ventilation? If there is only one person doing the CPR, if there's only you doing the CPR, then you will give 15 chest compressions, and after that you will give 2 ventilations. You will change your position, and then you will go for 2 ventilations, 2 rescue breath. But if there are 2 people, 2 rescuers, you can provide 30 chest compressions, then wait for the other person to give 2 breaths. Okay, after 2 minutes of doing this, you will again check for the pulses. Okay, so every 2 minutes in the CPR algorithm, you're going to check for pulses. And if you cannot find the pulse still, you will continue the CPR, and every 2 minutes you will check for pulses, and you will wait for the help to arrive, for the person with AED to arrive. I will show you how to use the AED, but until the AED arrives, you will do the CPR. And if you find the pulse in the process of doing the CPR, if you find the pulse, then the circulation is back, so you can just do the ventilation till someone arrives and helps you with oxygenation. For example, brings a mask for oxygen, maybe even intubation or something like that. Okay, are we clear on the algorithm? If there is anyone who wants to come. Sorry. Okay. Here I have a movie showing how we should use the automated external defibrillator. Please tell me if you can see the movie.
For help now. Remove all clothing from patient's chest.
Can you see it? Can everybody see the film?
Handle to open bag. Look at pictures on pads. Heel.
No, you cannot see the movie. I will answer you, dear Zahra, after this, but I don't know why we have problems with the films. I could not show you the films when it was out of the PowerPoint today. I shared it inside the PowerPoint, but still we cannot see the movies. I will try again. Tell me if you can see it.
Off blue plastic. Apply pad to bare skin, exactly as shown in the picture. Press pad firmly. Seal other pad off.
You couldn't see the seal, right? So I will share it by this way. Wait just a second. Tell me if you can see this.
Call for help now. Remove all clothing from patient's chest. To open bag. Look at pictures on pad. Peel one pad off blue plastic.
Okay, I have officially tried everything, so we will just continue, and then I will share the movie on your groups. Okay, it is a very informative movie, so we'll just go back to our PowerPoint. Okay, and I want to answer Zahra now about her question. She said, if there's only one person, should we skip breathing? And in that case, should we continue even after 2 minutes? Okay, no, you should not skip breathing. If there is only one person, you as the only person, you will give 15 chest compressions, okay? Then you will turn around and you will give 2 breaths, okay? 2 breaths. So 15 chest compression, 2 breath. Again, 15 chest compressions, 2 breath, 2 breath. And the rate of giving chest compression is 100 chest compressions per minute. Okay, so after 2 minutes, you will check again for the pulse. If there is no pulse, you will continue doing this 15 to 2. Okay, you understood? Is that clear? If there are 2 people, then the one person will provide 30 chest compressions, the other person 2. And it's easier because you will not have to change places for just doing ventilation and chest compression. You will give 30 chest compressions, the other person 2 ventilations. You will give 30 chest compressions, the other person 2 ventilations. Is that okay? Did you understand, Zahra? Okay, I will share this movie afterwards with you, but I have a question to ask. This is going to bother me. Now it will not go for here. Okay, so look at this picture here in the bottom right. Are you seeing it clearly? Okay, this is how we put the AED pads on the body of a child, okay, or an adult. It's not different. It doesn't differ. There are 2 pads for automated external defibrillator. Automated external defibrillator is what we use in ambulances, in basic life support outside the hospital, okay? There are 2 pads. You put one pad here, as you see, above one breast, the other one on the lower part of the other breast, okay? So if the patient is less than 8 years old, excuse me, here I have a problem again with the monitor. If the patient is less than 8 years old, the body surface is very low, so we cannot put the 2 pads on the front side. You will put one pad on the front, the other one on the back. Is that clear? The movie was explaining about this. I will share the movie later. So you will put the AED on the body. The AED will detect the rhythm and will provide a shock, okay, when needed. So you do the CPR till the AED arrives. Then you move back and you put the AED on the body and the AED will provide the shock. I have a question here. Do you know the answer of this question? I will change the place of this here. You had found a 5-year-old boy unconscious lying on the ground in a park. You were doing the CPR when AED. The victim was shockable and AED provided a shock. What will you do immediately after the shock? A, check for the pulse. B, check for the rhythm on the EKG. And C, chest compression. You will do chest compression. Can you tell me which one is correct here? You can just tap it, A, B, or C. Okay. Zahra said A, Akife said checking the pulse. Any other ideas? This is a very tricky question, okay? It's very important to know. Okay, I'm ready for answers. And now that there are 13 of us here, I would like to get to know you better too, because we were only 4 before. I couldn't ask for you to introduce yourselves, but I will ask you to introduce yourself soon, in a few minutes. Okay. I think all of you have answered check for the pulse. Okay, well, this is not right, and it is very important why, so pay attention. When you provide AED, when you provide a shock, whether it's by an AED, whether it's by a defibrillator inside the hospital or cardioversion inside the hospital, it is very important to continue giving the chest compressions. You will not check for the pulse immediately after the shock, okay? Because you will have to give some time to the patient's circulation to hit back, okay? You have given the shock. Now you will have to push the heart to recirculate, okay, the blood inside the body. After 2 minutes, you will check for the pulse. This is important. Why? Because it's not, showing nothing to us if we immediately after the shock check the pulse. Maybe there is no pulse, but it's not important for us because we will rely on the pulse that we check after 2 minutes. Whether the pulse is present after the shock or is not, we will continue giving pressures, and then after 2 minutes, we will check for the pulse. If the pulse is back, then we can stop the chest compression and we will only give ventilation. If the pulse is not back, then we can continue CPR, give ventilation, give chest compression, and also we can give another shock. Okay, are we clear? Are there any questions on this subject? No. Okay, so. Okay. So can I have a volunteer here to introduce herself or himself and tell us about his or her nationality, her age, his age? I will repeat. I'm Dr. Kousar Asna Ashari. I'm a professor at Children's Medical Center. And well, I come from Iran. In fact, the north of Iran, but I've been living in Tehran for 11 years. What about you? Can somebody turn on his or her microphone? Because I think I'm the only one who is speaking, and I think we will have a better atmosphere if everyone talks here.
Salam, everybody.
Salam.
My name is Rangarema Kuka. I come from Zimbabwe.
You come from where?
Zimbabwe.
Zimbabwe. Okay.
Yep.
And how old are you?
27.
27, great. Okay.
I love medicine, and maybe I'll become a pediatrician because it's sweet and interesting.
It is sweet. It's really sweet. Okay, great. Thank you, Ranga. I've always called you Ranga. I think it's Rangaria. Yeah, right?
My mom calls me Ranga. Ranga is the correct one. Thank you.
Okay. I can be like your mom, calling you Ranga if it's okay with you and your mom. Okay. Thank you very much for sharing with us. Okay. Anybody else? I'm 29. I cannot be exactly like your mom, but like an older sister, maybe. Yeah. Okay. Anybody else? Be courageous, like Ranga. One volunteer, and I will continue. I will be very much happy to hear from the Iranians too. It's a pleasure to hear from you guys.
Can you hear me?
Yes, of course.
Hi, I am Zahra. I'm from Iran, north of Iran, and I'm 24 years old.
Great, Zahra. Thank you. What specialty do you think you will continue your studies in?
I'm not pretty sure, but I think I'm interested in internal medicine.
Great, that's great. Thank you very much, Zahra.
You're welcome.
Okay. Anybody else wants to share? Okay, whenever you want, feel free to turn on your microphones. Okay. So we will continue. It is very important to know that CPR quality is crucial in maintaining the life of the patient. Okay, CPR quality can play a very important role. The child will die if you do not provide a high quality CPR easily. Okay, you're paying the time and you're devoting yourself to the patient, so pay attention to do a high quality CPR. Okay, you should push hard. What I mean from pushing hard is that 1/3 of the AP diameter should go down and then come back with each push. 1/3 of the AP diameter at least, okay? And then you should push fast. You should push at least 100 times per minute. And the very important thing is that you should allow for complete chest recoil. It's very important not to do something like this. Look at my hands. Many people do this, okay? This is not right. You should push, okay? And then pull back, okay? You should allow for complete chest recoil. The chest should come to the point that it was before pushing, okay? It's very important. Do not lose the contact of your hands with the body, but you should release the pressure after each push. You should allow for a complete chest recoil. After that, you should minimize interruptions, okay? When you're changing your position with the other person, there should be no interruption, okay? You should do it very fast. And try to rotate compressor every 2 minutes because the compressor will be tired and the pushing will not be efficient. Breath. This is important too. As you see in this picture, the woman is tilting the head and lifting the chin of the child, tilting the head with one hand and lifting the chin with the other hand. Whether you're going to provide breath by your mouth or by umbo bag, this step is crucial. If you're in doubt of a spinal injury, you should avoid this maneuver. What should we do if you're in doubt of a spinal injury in place of head tilt chin lift maneuver? Can you tell me? We've got an answer here. Jaw thrust, right? Okay, fair. We should do jaw thrust. Okay. I have not put the picture of jaw thrust here, but it's just pulling the jaw instead of moving the head, because if you move the head, the spine will be in danger. But if you just pull the jaw, you will open the airway of the child without putting the spine in danger. Okay. Like mask ventilation, it is a very important step in CPR. You should provide 100% oxygen. It's not much different with ventilating by your mouth, but if you're inside the hospital and you have access to bag and mask or ambo bag, you will do this instead of ventilating by your own mouth. You will give 8 to 10 breaths every minute in CPR, but if perfusion is okay, it means that if you have pulse, okay, you will give 12 to 20 breaths per minute, okay? So this is when you're not pushing the chest, you're only ventilating. And this way is as effective and probably safer than intubation even. This is the algorithm of ALS, Advanced Life Support. I'm not going into detail because the class is intended to be for stagers. I will not give you the doses or the numbers, but I will talk about the general points. Okay. Then you are faced with a patient with cardiac arrest inside the hospital. Cardiac arrest means no pulse, okay? We have different algorithm for bradycardia, and we have a different algorithm for tachycardia. This algorithm is for cardiac arrest when you have no pulse, okay? You will shout for help, first of all, like BLS, like basic life support, and you will activate emergency response. Because you're inside the hospital, many people will come to you and will help you, okay? You will start the CPR, you will give oxygen, and you will attach monitor or defibrillator to the patient. You will check if the rhythm is shockable. We have two rhythms known to be unshockable and two rhythms known to be shockable during the cardiac arrest. Look here, this is the picture of an asystole. The asystole is when the heart cannot work at all, okay? This is just a flat rhythm, okay? There is no rhythm seen inside the heart. And pulseless electrical activity is another unshockable rhythm, PEA. You can see here that it appears just like a normal rhythm, okay? But you have no pulse, so the rhythm is false, you know, somehow. It means that maybe the epinephrine that you gave to the patient, maybe the pressures that you gave to the patient has made this pulse, but this pulse is unreliable. The patient does not have any heart rhythm, okay? So you may see this rhythm, but you will still have to do the CPR, okay? So look here, we have asystole or pulseless electrical activity. If you have these two rhythms, you will do the CPR for 2 minutes, then check again for the pulse. You will not provide the shock here, okay? Because the rhythm is unshockable. After that, you will have time to get the intraosseous access, IV access. I will talk about the intraosseous access afterwards. And you will insert epinephrine every 3 to 5 minutes, and you will consider advanced airway. I'm not going into further detail. I will just tell you about the general ideas about the shockable rhythms and unshockable rhythms, okay? But if you have VF or VTAC, then you can provide the shock. I will show you the pictures of VF and VTAC here. Okay. In the picture above on the left side, you can see VF, ventricular fibrillation. Ventricular fibrillation is when the heart just trembles, like my fingers, you know? There is no effective rhythm, the heart just trembles. Tachycardia is when the heart, well, is tachycardic, but the origin of the waves of the heart are from ventricle. So you see QRS waves that are wide, and you can see no P waves because the origin of the waves are in the ventricle, okay? And it's somewhat regular. It's not like the VF that you can not see any rhythm-like thing here in the VF, okay? And here's torsade de pointe. Torsade de pointe is a type of ventricular tachycardia in which the rhythms move around a circle, okay? You can see that the amplitude of the waves are becoming higher and higher, and then lower and lower, and then again higher and higher, lower and lower. It's somewhat like ventricular tachycardia, but it's very frightening because soon it will change into VF, and we should do something about it very quickly. And here on the right bottom EKG, you're seeing a wave. It's a very interesting and important wave. I do not expect you to know this, but if anyone is able to recognize this rhythm, that would be really great, and I will give him or her a prize. Can anybody see or say what the diagnosis of this rhythm is? I will wait for a few seconds if you can detect the rhythm. Okay, this is a very important rhythm, as I told you. This is a kind of ventricular tachycardia. As you see, the QRSs are wide and there is no P wave, and the heart is tachycardic. Okay, someone has answered. Flutter? No, dear Kiana, it's not flutter. If you want, I can, in another session, explain about all heart rhythms for you. But this is just for differentiating from other ventricular tachycardias, okay? We have another answer. Yes, please. Torsad. No, Torsad is the one that I showed here on the right front part. Okay, Torsad de Pointe. Okay, this one is a type of ventricular tachycardia because you cannot see any P wave. It's in that way like Torsade de Pointe. But Torsade de Pointe, as you see here, has amplitudes changing, amplitudes being higher and then lower, okay? Here, the waves are like sinus wave, as you can see, like sinus, okay? Sine wave. We call this wave sine wave because it's like the sinus wave, and it is seen in hyperkalemia. It's very important. As you can see, the T waves are tall and peaked, and you also have wide QRS. Okay, you might have a patient with no original electrolyte level, base electrolyte level, and you see this wave during the CPR, and you say, wow, this is hyperkalemia. It's very important because we know how to manage hyperkalemia, okay? The important thing is to infuse calcium for protection of the heart. So we infuse calcium gluconates, okay? So it is very, very important to know this rhythm and to manage it very quickly. I just wanted to point this out because it might be interesting to you and you might see it in the CPRs. But if you didn't know it, it's not important at all because it's soon for you to know these rhythms. Okay, no, it's not finished yet. I will go back to the algorithm. So we were here that we understood that the rhythm is VF or VTAC, and VF or VTAC is shockable. So you will provide a shock. And what did I tell you about what you should do after the shock? You should immediately continue your pressures. You should not wait for the rhythm to change. You should not wait to check for the pulse. You should just continue doing the CPR, and after 2 minutes, you will check again for the pulse. If there is no pulse again, and if you look at the rhythm and it's still VF or VTAC, you will give the shock again. Then again, you will, for 2 minutes, continue the chest compression. After that, you will check for the pulse, look at shock again. It's noticeable here in the algorithm that after the first shock, when you're about to give the second shock, it is very important to give the epinephrine. And after the third shock, it's good to infuse amiodarone. Again, it's a little hard for you to memorize now, but it's good to know, especially epinephrine. Epinephrine plays a very important role in CPRs. Your book, your Nelson Essential book, talks about the drugs in CPR. I'm not going to bore you much with this because you can study it by yourself, but it's only important to know that epinephrine is the most important drug during CPRs. You will give this epinephrine to pulseless patients when you're providing CPR. If the rhythm is shockable, even if the rhythm is unshockable, you can give the epinephrine. It's very important. And it's important to note that sodium bicarbonate is not administered routinely, okay? This is not the first choice that we use. There are explanations on your book, but just know that it's not a routine drug. Calcium is a very important drug, not routinely recommended, but if you have hyperkalemia, for example, as I showed the rhythm to you, or you have hypomagnesemia, you're sure that you have hypercalcemia, or the patient has overused calcium channel blocker, calcium. Glucose is you should do the BS glucometry, and if low glucose level is detected, then you will give glucose. The picture of intraosseous injection. I will share the movie of intraosseous injection with you later because apparently we cannot do this here. Maybe it's my problem, my internet problem. But it's important to know because when you cannot provide an IV access then you have this option. All the drugs that can be used in the CPR can be administered via intraosseous injection. It's very important and it's easy, but we are all afraid to do it. Maybe it's a little hard for us to perceive. You should insert a needle in the proximal part of the tibia. The other bones are available too, but this is the best part that we can use in children. Proximal of the tibia in the medial part with a gun or with a needle. Okay, we have this gun, this very interesting gun in our ER in Children Medical Center. But maybe in some hospitals there are no guns, but needles can be used too. Okay, just be familiar with the concept. I will show you the movie later. And cardioversion or defibrillation. Does anybody know the difference between cardioversion or defibrillation? I just want you to know this because you might have heard it and it's written in your book too. And I want you to choose the correct word. Can anybody tell me the difference? It's hard a little. Okay, I will tell you myself then. No one? Okay. The pictures that you're seeing, they are the same, okay? This is a device, a defibrillator. You can do cardioversion or defibrillation with this device. It's not different, okay? And these are the pads that you use for cardioversion or defibrillation. It's a little different with AED, as you see. The AED had thin pads because it's portable, and you can use it in the ambulance, outside the hospital, but these are big devices, big pads, okay? The difference is in this area. Cardioversion is used for supraventricular tachycardia, okay? Supraventricular tachycardia, well, this is a rhythm. The patient has pulses, okay? So you will not need a high energy. The patient already has a rhythm. You will only need some energy to just reverse the rhythm to a normal rhythm, okay? But defibrillation, this expression is used for pulseless patient, for VF or pulseless ventricular tachycardia, okay? When you want to apply an energy to a pulseless attack or VF, you use the word defibrillation. You will need a higher energy and you will use asynchronized form. Why asynchronized? Because you do not have any rhythm to be synchronized with. So you should use asynchronized form of energy. But for cardioversion, you will use synchronized. It's important to know because when you want to set up the device, you should choose these forms, synchronized or asynchronized. The quantity of the energy, these are important, okay? I have shown you these rhythms before, and I think I'm done with explanation of CPR. It was a very general session. I did not go into further details. If you want, I can just have a class for you about the details of CPR. And I think I might need a class for just showing you the movies, but I will share them to you on your group. I will be glad to answer your questions now. Any questions? Do you think you will be able to handle the CPR by yourself now? Zahra has asked, are the voltages used for children different from adults? Yes, Zahra, they're different from the adults. Please have a class about the heart rhythm. Okay, sure, I will have a class for heart rhythms. If you want, I can talk about the voltages too, but I think it will be a little complicated now. I will have the class for heart rhythms and I will provide a table for the voltages also. I think that will be helpful. I can share it on your group too. I think it's a little hard here. For all in all, okay. Heart rhythms, okay. I can say that we start with 2 joules per kilogram for cardiac arrest in children, okay. 2 joules per kilogram. Then you will increase them to 4 joules per kilogram, okay? And then you can increase it to the adult voltage. But first of all, you start by 2 joules per kilogram for cardiac arrest. For the drugs used, okay. For the drugs used for for abnormal heart rhythms, you mean, Zahra? Or for CPR? Okay, of course, I will be glad to. You're welcome. Any comments, any questions? I will be glad to answer. You're welcome, dear Akefel. I wasn't present for the start of the class. Can we have the recording? Yes, of course, we will share the recording of the class. You're welcome. You're welcome. It was great to have you here today. You're welcome, Hoda. Okay, if there is no other question, you're welcome, Fateme. Have a great evening, a beautiful rainy evening, and goodbye.